Yeah. So how are you planning? What would be your talk structure like?
Well, basically, I'll just give two cases where we did hemoperfusion on our severe COVID patients. Okay, so the first case actually was not given a tocilizumab, and the second case was already given a tocilizumab, however, did not improve. So we were called in to do the hemoperfusion, and the patient eventually had was able to survive. Both of them did not get intubated. They were just on high flow. Okay, and then it was quite good results because it was the markers were improved. The O2 requirement eventually, the O2 requirement eventually went down early. Okay, so those are the basically what we did in our the cases, the experience, and then I got to show one paper with local data. However, the subjects are dialysis patients. Okay, and the other paper is an international paper from Iran with some data also. For the local data for our acute, we're still collecting it, so it's not yet available. But maybe in the next end of the year, we will be able to show it also.
Sure.
Doctors, I think like it's 6:30. Shall we start the webinar, sir?
Sure.
Yeah, surely.
Yeah. On behalf of Jafran, I take immense pleasure in welcoming the respected speakers as well as the doctors who have joined this webinar across the globe. And I'm sure today the two respected speakers are ready to share their rich clinical experience on the role of hemoperfusion in COVID-19. So I'm sure this webinar would be of interesting to all the participants. So with that note, I would like to introduce the theme of the webinar, Hemoperfusion Therapy in COVID-19, Principle and Practical Experience. And we have got two speakers, Dr. Eric Chua from Philippines and Dr. Rtiesh Aggarwal from India. So Dr. Eric Chua is going to give a talk on role of hemoperfusion in COVID-19, a Philippine experience. And Dr. Rtiesh Aggarwal will give a talk on hemoperfusion as a potential adjunctive treatment for critically ill COVID-19 India experience. So it's a kind of a collaborative clinical experience sharing from between Philippines and India. First, I would like to introduce the first speaker, Dr. Eric Chua. Dr. Eric Chua holds various important positions in Philippines. He is the active consultant of Department of Medicine of Chinese General Hospital and Medical Center, and the active consultant of Department of Adult Nephrology of the National Kidney and Transplant Institute, Philippines. Dr. Eric Chua is a fellow of Philippines College of Physicians and a fellow of Philippines Society of Nephrology. He is a member of Philippines Medical Association and a member of Filipino-Chinese Medical Association. Dr. Eric Chua is the author and co-author of numbers of research papers. So I cordially invite Dr. Eric Chua to give a presentation on role of hemoperfusion in COVID-19, a Philippine experience. So here I also would introduce the second speaker, and then I would hand over the session to Dr. Eric Chua. Dr. Rtiesh Aggarwal, the principal consultant in critical care of Max Smart Hospital, Saket, Delhi. He is an European certified intensivist with an experience of more than 15 years. He has won many awards and recognitions, including the prestigious BMJ South Asia Awards 2017 and the International Asian Hospital Management Awards. He has participated in many national and international clinical trials and has publications with his high influence. Dr. Rtiesh Aggarwal's area of interest are mechanical ventilation, antibiotic stewardship, end-of-life care. So with this, I complete my introductory session. Over to Dr. Eric Chua.
Okay, so let me share my slides.
Yeah.
Okay, so can you see my slides?
Yeah, sir. we are able to
Okay, so
discuss.
thank you. So again, thank you for, it's an honor to be part of this webinar today. So today I have been invited to talk about the role of hemoperfusion in COVID-19 at Philippines experience. Okay, so this is the scope of my presentation today. Okay, so the first part, I'll be presenting two cases that I handled of COVID-19 who are given hemoperfusion. And then next, I'll discuss a little bit about the role of hemoperfusion in COVID-19, and I'll show you some evidence that we had, okay, locally and some international publications that I was able to gather for the role of hemoperfusion. So the first case, okay, I would like to present a case of a 50-year-old male who was diagnosed with known chronic bronchitis, okay. She came in with chief complaint of shortness of breath with a 5 days history of cough and generalized body weakness, okay. At home, he tried to check his O2 sat, which actually dropped to 77% at room air, and was subsequently improved to 85% upon hooking to O2 of nasal cannula of 6 liters per minute. With the persistence of the desaturation, he was brought to the emergency room, and the vital signs of the patient was at this time stable at 120/80 with the cardiac rate of 80. However, the O2 sat was 95% only upon, it improved to 95% upon hooking the patient to a 15 liter per minute of non-rebreathing mass. Okay. So initial diagnosis at that time was to consider a COVID-19 pneumonia. Okay, this was the chest X-ray of our patients on admission, and a swab test was immediately done on this patient upon admission, and the result came in immediately within the day, and it showed actually positive results. Okay, so these were the initial baseline laboratories that were presented in this patient. He has a lymphocytes of 10, okay, white count of 7.6 with an SLDH in one of our hospital, but this is the markers that we usually do in our hospital. SLDH was 1,340. The procal was normal. The ferritin was initially high at 3,000, and the HSCRP was 9.1. The ABG was done on this patient initially, which showed actually a metabolic alkalosis. However, the PF ratio is only 155 with an O2 sat of 96%, and this was classified initially as a moderate ARDS. So this was the X-ray done on the second hospital day. There was some progression, okay, and this was the ABG again repeated on the next following day. Actually, you can see that the PF ratio dropped to 118, despite we increased the FiO2 at that time to 100%. So this was classified as again as moderate ARDS, and we did the initial screening of COVID gram risk scoring, which was high risk for developing complications of COVID-19. So immediately this patient was managed by an infectious disease doctor and a pulmonologist. Okay, upon admission, they started patient initially on dexamethasone, enoxaparin, and remdesivir. Okay, patient was also hooked to a high flow nasal cannula at 100% FiO2. The patient was initially planned to be given Tocilizumab. However, at that time, because there was a surge of our patients of COVID, there was a shortage of the Tocilizumab. So it was not given, it was not available. Instead, we were referred to nephrology service at the time for hemoperfusion. So the patient eventually consented for hemoperfusion, and we were able to do 3 sessions of hemoperfusion with a combination of isolated ultrafiltration for 3 consecutive sessions by the IJ catheter access. This was the hemoperfusion prescription that I did. So we gave a blood flow of 250 cc per minute. The duration of treatment was only 3 hours. And we were able to ultrafiltrate of 2 liters in the duration of 3 hours. Okay, and we also gave anticoagulation of 0.2 cc and enoxaparin. And the cartridge that we used at the time was a HA330 hemoperfusion cartridge. These were the subsequent X-ray. Okay, the X-ray was done almost daily. Okay, as you can see, there was progression. However, in the subsequent, it's still progression, but it was this one, the second and the third one actually on the same day was repeated. And then these were the X-ray, this one. This was the CT scan that was done on this patient on admission. Actually, it showed 70%, almost 70% of ground glass opacity and areas of consolidation. However, you can see that we were able to do the hemoperfusion on the 2nd to 4th day. Okay, and you can see that after the 5th day, we rechecked the SLDH and the ferritin, where was actually decrease of the SLDH and the ferritin. Okay, and then in day 6, this was the and the days that we repeated an ABG, and you can see that the PF ratio already improved at this time. Okay, and the X-ray upon discharge on day 7 was actually already there was resolution of the infiltrates. So the patient had the COVID swab negative done on day 7, and the patient was discharged eventually on day 7 with no O2 support. Okay, so this was the first case that was done with hemoperfusion. The second case is another 75-year-old male. This time around, it's a known hypertensive for almost 30 years. He was on amlodipine and clonidine. Okay, he again came in with a shortness of breath of chief complaint. He has 4 days history of cough and sore throat, and he actually had a swab, COVID swab done on the 3 days prior to admission. He went to an emergency room. Okay, however, that time the results were actually still normal. He was not requiring O2, the ferritin were normal. So the patient was advised again home treatment and quarantine, because also that time that he went to the emergency room, there was already a surge again in our the country. Okay, however, 3 days after, the patient suddenly developed desaturation of 94% with increased dyspnea. Hence, he was went back to the emergency room. And this time around, upon emergency room, the O2 was done and was with 99%, but however, it requires 5 liters of nasal cannula to achieve that. ABG was done again on that admission, and it actually showed respiratory alkalosis with a PF ratio of 230 on admission. So you can see this X-ray. Actually, this is the CT scan film. No, I was not able to get the X-ray of the patient on the 3 days prior to admission, but at that time the X-ray was still okay. But however, on the right side, you can see that this is the X-ray upon admission, and the CT scan result also on admission was this one. Okay, at this time around, the CT scan showed there's peripheral bilateral ground glass opacity with consolidation in right middle lobe. And the reading what time was there's a consistent with progression of COVID-19 pneumonia. So these were the laboratories that was done initially 3 days before admission. As you can see, the ferritin, the SLDH, the Procal, and HSCRP are quite low at that time. However, during admission, the ferritin was already increasing. The SLDH was also increasing, and the HSCRP also increased 10 times. Okay. So on admission, patient again was given the usual protocol of dexamethasone, enoxaparin, and remdesivir. Initially was hooked to high flow nasal cannula of 60%, was doing okay, and the patient was given tocilizumab of 400 milligram on the first hospital day. However, 2 days after giving tocilizumab, they rechecked the inflammatory markers. It was actually on an increasing trend. Okay, and this time around, also patient complains of increasing dyspnea. So the pulmonologist actually increased the high flow nasal cannula to 100% FiO2. Okay, and then the IDS, infectious disease doctor, actually there was eventually referred as the nephrology service for hemoperfusion. A baseline ABG was done at that time. Okay, it actually showed a normal acid base. However, the PF ratio dropped to 117 despite 100% high flow nasal cannula. So upon a referral to us, we actually, the patient consented. Okay, so we again did 3 sessions of hemoperfusion, again with a combination of isolated ultrafiltration for 3 consecutive days via IJ catheter access. So this was again the same prescription, almost the same as the first case, but this time around I only gave 0.1 cc of enoxaparin on this patient, and ultrafiltration that I did on the patient was only 1 liter for 3 hours. Okay, and we again used the H8330 cartridge for this patient. So comparing the X-ray, as you can see on the upper left, this is the X-ray on pre-hemoperfusion, okay? And then these are the subsequent X-ray, the 9th hospital day, post-hemoperfusion, and then 2 weeks after, you can see that there's already resolution of the infiltrates from the patient. However, sadly, there was no CT scan, no repeat CT scan was done on this patient, okay? And you can see that the markers, okay, however, in the markers, you can see the 7 and the subsequent days, the ferritin actually was slightly higher, no? But the HSCRP, you can see that there was a decrease of the HSCRP on the 7th hospital day and eventually on the subsequent days, okay? The patient eventually was weaned off O2 support, okay, after 3 weeks, okay? I think around 10th hospital day, he was already back to nasal cannula from the high flow. And then eventually after 3 weeks, he was weaned off from O2 and discharged with no O2 support after 1 month. So those 2 cases shows the patients who were actually having severe COVID-19. And then we were able to do hemoperfusion and was able to discharge the patient with no O2 support upon discharge. So we now go to our discussion. So as you can see, as we all know, the COVID-19 is a global pandemic. Okay, in the Philippines, the first case was actually detected around January 2020. Okay, and then by March 2020, our country actually went into a so-called enhanced community quarantine or lockdown, no? Since from March 2020 up to now, there's already been reported 1 million cases as of May 2021. We had two surges actually around July to August, and the most recent is around March. We had another big surge where more patients were admitted. Okay, our hospitals were overwhelmed almost with the number of cases admitted in our hospital. So COVID-19, as we all know, range from presentation can be from mild common cold illness to severe pneumonia, viral pneumonia leading to ARDS. As we all know, the risk for severe disease development are those patients with our elderly, with comorbidities, and those with already some pneumonia at the start. Okay. In one study published in June 2020, we all know that SARS-CoV is the causative agent of COVID-19. Majority still are asymptomatic, and only 15 to 20% will require hospitalization. However, there's around less than 5% who became critically ill, which can develop ARDS and multi-organ failure. So this is one of the interim management guidelines for COVID-19 that we have in our country that we follow. So we have the low-risk patient. As we can see, some of our patients have mild symptoms, some even don't have symptoms, no pneumonia and no hypoxia. So they're actually sent home with isolation. Most of these patients have no comorbidities. For the moderate risk patients, those patients actually have pneumonia, but still not oxygen requiring. So some of these patients actually were discharged home, discharged in home quarantine, but some of them still were admitted. Okay. However, most of the high-risk patients are those patients with these risk factors, like elder patients with pre-existing pulmonary disease, patients with CKD, with diabetes, hypertension, and those transplant patients. So most of the laboratories that we have for this high-risk patient will actually show CBC of leukopenia with lymphopenia. Our CRP is usually high. Procalcitonin is usually normal. And we have also high D-dimer for those patients with high risk of hypercoagulability. LDH and ferritin is usually the ones we do, which are actually elevated. And of course, our X-ray will show bilateral infiltrates, and the CT scan most of the time will show ground glass opacities. So these are some laboratory findings in our patients if we are presenting with cytokine storm. Most of them will have increased CRP. Our patients sometimes will have some low hemoglobin. The WBC can be low, can be high, and most of our patients will have low platelet. And they will also have D-dimer, increased ferritin. If your hospital or institution have these inflammatory markers, we can actually have monitor this interleukin-6 and interleukin-10. Sadly, in our country, it's not readily available. It's only recently that some of our hospitals have already this interleukin. So most of our laboratories don't have this one. So in the first few cases, we were not able to do these interleukins. So also we work for our patients for infection, other infection, and also we assess the renal and liver function. So obviously we all know COVID-19, patients who has this pathophysiology, okay? Most of our patients who develop COVID-19, severe COVID-19 will have excess immune response. There will be noted increase of the interleukins 2, 6, okay? And then it will trigger a local and systemic inflammatory response, which can actually lead further to hypercoagulability. And those patients can actually present with macrothrombosis, which can present with pulmonary embolism. And for those micro thrombosis, they can present with ARDS, leading to hypoxia. And if your patient is in cytokine storm, they can actually also lead to the so-called multi-organ dysfunction. No? So our patient can actually sometimes present with heart injury. So like side of them will have myocarditis. Renal injury is also present. However, usually we see this in the latter stage. Okay, and our patient can also have some liver injury, the lung injury, which present with pneumonia and ARDS. Some of our patients also develop stroke, which have present with neurologic manifestations. So in COVID-19, in this pandemic, we actually were able to demonstrate in cytokine storm that the critical role of an effective host immune response and the effects of immune dysregulation. And this is what we call the cytokine release syndrome. So usually our patient will have increased level of circulating cytokines, and there will be immune cells hyperactivation in our patient presenting with cytokine storm. So this is the unifying definition of cytokine storm in one study in the New England Journal. So they state that there's usually increasing level of cytokines, circulating level of cytokines. The patient will have acute systemic inflammatory response, and there are also some secondary organ dysfunction present in our patients. So this is one of my favorite slides. Okay, as you can see, in patients who have developed sepsis or septic shock, it can be can be caused by these so-called pumps. Okay, these pumps actually are secondary to infection, can be actually virus, fungus, or bacterial or any parasitic infection which cause tissue injury. This will actually lead to the so-called pathogen-associated molecular pattern or the PAMPs. Okay, in our other patients who have actually trauma or have severe burn or have pancreatitis or surgery, they can also cause tissue injury, this time around releasing the so-called damage-associated molecular pattern, ways to these two pumps and dumps can actually enter our cells and activate the receptors, which can lead to the so-called cytokine storm, causing tissue organ damage. So in patients who have cytokine storm, we have to achieve this goal of balancing the immune response because we need sufficient cytokines production to eliminate the pathogens that cause this dysregulation. However, too much cytokines can actually cause some collateral damage. So therefore, we have to avoid this hyperinflammatory response to eventually achieve the so-called homeostasis. So therefore, we have to identify the right timing for giving the so-called extracorporeal therapy, which can actually, it's one form of blood purification to remove cytokines. So we will discuss, so you can see in this figure, it's divided into the phase A, phase B, and phase C. So let's start with phase A. So in phase A, you can see that the red lines is actually the pro-inflammatory arm and the blue lines is the anti-inflammatory arm. So when a patient is exposed to an infective insult, the initial response is the pro-inflammatory arm will cause the increase of our in our body, okay, and then this will be followed by an increase of the anti-inflammatory arm. So in phase A, some of our patients, if you have a good immune response, can actually improve on its own. Okay, they do not necessarily progress to a severe one. So these are usually the patients that we see in the mild and moderate COVID patients, where they after this patient we just give some supportive therapy and they actually improve. Okay, so giving extracorporeal therapy at this stage will actually be harmful because the patient actually may improve already on its own. So giving this seems to be excessive if we give extracorporeal therapy. So before we go to phase B, let's go back to phase C. So in phase C, as you can see this time around, the anti-inflammatory arm is already higher, okay, and the pro-inflammatory are actually on the way down. So, okay, if we give again extracorporeal therapy or blood purification in this phase, it will actually be more harmful because our patient may, at this time may already be in the recovery phase. So the best time to give the extracorporeal therapy is actually in the phase B. As you can see, the phase B is already the so-called cytokine storm. Both the pro and anti-inflammatory arm are increasing, but you can see that they are not in a balanced state because the pro-inflammatory is very high and the anti-inflammatory arm, even though it's increasing, is at not in balance level. No, so if we give it extracorporeal therapy in this phase, we are actually able to remove both the pro and anti and making it lower and make it into a threshold level, which our patient can actually become achieve the so-called homeostasis. So the difficulty of the timing is actually we have to identify if our patient is actually already in the phase B, because if we are able to identify it, then it's the right indication to give the so-called extracorporeal therapy or the blood purification in our patient presenting with cytokine storm. So what are the therapeutics that is available for a patient who has a cytokine storm? So as we all know, this has been available in the literature. Okay, in our country, we were able to get, of course, we're giving steroids, which is in the form of dexamethasone. Tocilizumab has been available in our country since the last year. However, sometimes if we have a surge, we will have a lack of, we have the shortage of the tocilizumab. Sometimes we substitute our with the baricitinib. Okay, most of the time we're giving the tocilizumab. So in our treatment for the COVID-19, so our infectious disease usually give antiviral or antibacterial treatment if there's a concomitant bacterial infection. We also give immunomodulatory technique, which can blunt the cytokine release, which may be beneficial when given appropriately and a proper timing. So our objective of giving this immunomodulatory treatment is to overcome the dysregulated pro-inflammatory response seen in sepsis. So what is the right time and when is the right time? Of course, we ideally is we have the so-called we have to do cytokine profiling. So we have to check if it's available, the interleukin 6 and the interleukin 10, and then we can give the cytokine targeting therapy, or we can give combination or sequential regimen. So in our country, we usually have these corticosteroids. We give some of our patients were given also immunoglobulin, and a lot of our patients were given blood purification, which is considered a non-pharmacologic intervention for treating cytokine storm. So in the interleukin 6, we all know we are trying to block that release of the cytokine. So we have been giving tocilizumab, which is an anti-IL-6, which is a specific anti-cytokine-directed approach. And if it's a non-directed anti-cytokine approach, we usually give the hemoperfusion, which can, like I said, can remove both the pro and anti-inflammatory cytokines. Usually the molecules that are being able to remove in hemoperfusion is around 16 to 60 kilodaltons. So these are some studies that shows that actually tocilizumab, we all know this, in the recovery trial, they were actually able to show that there's a significant decrease of death in our patients. And in the meta-analysis, which included 26 studies, they were also able to show decreased all-cause mortality of giving tocilizumab. Okay, so this is, I want to show you this parang algorithm that we have in our country, in one of the hospital where I work in NKTI. So you can see that in COVID-19, we will have to classify our patient again to mild, moderate, and severe or critically ill. In mild and moderate patients, we usually just do home monitoring, send home the patient, if particularly the patients does not require O2 supplements. However, in our patient with severe and critically ill patient, we usually hook the patient to a high flow nasal cannula. Okay, if ever it's not tolerated, the patient also will have to be intubated eventually. We also try the patient on a self-proning of at least 16 hours per day. And as you can see, we give the protocol of dexamethasone, tocilizumab, and remdesivir. And however, if after giving first or second dose of tocilizumab, or if there's a contraindication of tocilizumab, that's the time that actually we subject our patient to hemoperfusion of around 4 doses, four consecutive doses, no, for our patients. So now we are going to show you some evidence that I gathered from the literature. So this is one study that I got from Iran. It's the effectiveness of hemoperfusion in patients with severe COVID-19. So the subjects, the methodology is a prospective experimental trial where the patients are classified as severe or COVID-19. So if your patient has a pulse PaO2 of less than 60, or if your pulse oximeter is less than 88, despite with no clinical improvement, despite non-invasive therapy, the patient were subjected to the treatment of 4 hours hemoperfusion using the HA330 with a combination of CRRT in the mode of CVVH times 3 days. So the data that they showed that they were able to do hemoperfusion on 10 patients. The average mean age is 57, and the outcome actually showed 6 out of 10 patients improved on hemoperfusion. They did some analysis on the pulse oximeter. You can see that there was an improvement of pulse oximeter before and after hemoperfusion, which is statistically significant. And the CRP also was showed improvement, again, was statistically significant with a drop of the CRP before and after hemoperfusion. For the interleukin 6, even though it was not statistically significant, you can see that there was a trend of a drop of the interleukin 6 levels. So the conclusion of this paper was that extracorporeal hemoabsorption or hemoperfusion could improve the general condition in most of the patients. However, this author also still suggested that we still need large prospective trials in carefully selected patients to see if definitely hemoperfusion is really effective in our patients. So I would like to show you one of the local data or local paper that I actually participated in this paper. So I work in a center where it's a national referral center for dialysis patients. So we had a lot of patients on chronic dialysis, both HT and hemodialysis and peritoneal dialysis. So actually, he had had COVID-19 during this time of the pandemic. Okay, so this is a study of hemoperfusion in COVID-19 among chronic dialysis patients. So as you can see, our dialysis patients has a higher mortality in COVID-19 of around 30% versus 5% in the normal population. And these are the risk factors for our dialysis patients. They are mostly elderly with multiple comorbidities, and dialysis patient by itself already have immune dysfunction, usually related to uremia. So they have therefore increased risk of infection, they have higher disease severity, and increased hospital mortality. So we decided to do a retrospective cohort, which compared with a match control. So our objective of this paper was to compare the outcome of our chronic dialysis patient with severe and critically COVID who underwent hemoperfusion versus the standard of care. And we are actually looking also for the 28-day mortality, the number of hospital stays, and usually the resolution of infiltrates and change in inflammatory markers. This was our protocol, our classification based on the our clinical presentation to classify our patient as moderate to severe to critically ill. These are the laboratory markers that we monitor in our patients. Note that in our patients, as I said, our patients are mostly dialysis patients. Ferritin is already high, even if our patients have no COVID-19. Because as we all know, if our patients are already ESRD, they are actually already on a chronic inflammatory state. So average ferritin of our patients on this data was actually around 711 nanogram per ml for ferritin alone. So if our patient has this level below, we don't really consider that patient probably have a storm. But however, if it's higher, we classified our patient probably will already having COVID-19 cytokine storm. So these are the indications for hemoperfusion for our patient. So if your patient was diagnosed with positive COVID-19 by swab, or we have severe critical COVID, our chest X-ray already showed multilobar or diffuse infiltrate, plus any of the two following markers. Okay, and our protocol, actually, our patient were subjected to hemoperfusion using the H8330 for 4 days. Actually, it's 4 consecutive doses. Okay, for 3 days. So based on the result, there was a total of 436 patients that had been admitted for COVID-19 during that time. 249 were actually on severe critical disease. Okay, 43 of our patients underwent hemoperfusion, but out of the, based on the inclusion criteria, we excluded the patient with kidney transplant with AKI and incomplete chart. 34 patients were subjected to hemoperfusion, and this was matched with a 68 control group, okay, with the 1:2 ratio with a patient of age, gender, and comorbidities, and the same quadrants of lung involvement. So this was the treatment that we did. We subjected our patients on hemoperfusion. So most of our patients are already chronic dialysis patients, so they have already the fistula. So they use the fistula. For those peritoneal dialysis patients who had severe COVID, we have to insert a temporary catheter for hemodialysis, for hemoperfusion. So this is our protocol. We use 4 cartridge therapy, which is a 2:1, a 2:1:1 ratio. So day 1, we subjected the patient to 2 cartridges, 12 hours apart. Okay, and day 2 and 3, we gave 1 cartridge per day. The duration of our treatment is only 2 hours, and we gave only blood flow rate of 150 to 200 ml. We only decided to do 2 hours because at that time we have so many patients. Okay, so if we do it the usual 3 to 4 hours, lesser patients will be subjected to treatment. So we have to shorten the treatment to accommodate more patients during that time because there are so many patients. Because of the short therapy of around 2 hours, we decided not to give any anticoagulation during those treatment. So these are the results. As you can see, the majority of our patients were male with a mean age of 52. So there was no difference in most of the baseline characteristics, except most of our patients in the hemoperfusion group had more dyspnea, more patients have fever, and they actually have a lower PF ratio compared to the match control. This was also another baseline characteristics. As you can see, some of our patients were all still given Tocilizumab on the HP group, 7 patients, but in the control group, none was given Tocilizumab, but 34 patients were given hemoperfusion on the HP group. Another difference in the baseline characteristics, the LDH was significantly higher in the HP group, okay, and there was lower PF ratio in the HP group. And in the results, okay, after 4 sessions of hemoperfusion, there was significant reduction in the level of LDH, HSCRP, and procalcitonin. All were statistically significant. And of course, and another thing is that there was increase in PF ratio after the 4th session of hemoperfusion, and was also again statistically significant. Overall, the 28-day mortality for our patients was actually 47%. But if you break down to the group, the HP group only had 32% of our patients died. And for those patients who had match control for the control, 54% of the patient died. So there was actually, if we compare it, there was a significant relative risk of 0.59 in our patients who were subjected to hemoperfusion. There was no difference in the number of hospital days and O2 support between groups. We further did a multiple logistic regression of the paper on the studies, and we are actually able to predict significant predictors of mortality for patients who have hemoperfusion. It was actually beneficial for our patient. If your patient have a PF ratio of lower PF lower PF ratio, it also is a significant predictor of mortality. And overall, patients who receive hemoperfusion were 5 times less likely to die compared to control. So the conclusion of this paper was state that among maintenance dialysis patients of severe critically COVID-19, hemoperfusion was associated with significant decrease in inflammatory markers, significant improvement in PF ratio, there was reduction in 28-day mortality, and the significant predictors of mortality were the hemoperfusion and the PF ratio. And HP or hemoperfusion was associated with the relative risk of 0.59. Currently, we're still doing some studies on our AKI patients. No? However, I think their data, we're still collecting the data. Maybe in the end of the year, we will be able to show you the data for the patients with AKI and not just those patients with end-stage renal disease. So I think this is my last slide. So for our final conclusion, as we all know, cytokine storm is a life-threatening systemic inflammatory syndrome, which involve increased level of cytokines in immune cell hyperactivation. So therapy should include, we can do a direct therapy of neutralizing the cytokines using the tocilizumab, or we can take a non-direct anti-cytokine approach, which is in the form of hemoperfusion. Hemoperfusion in COVID-19 seems to be promising. I think, in our opinion, we need further and bigger studies, maybe, to see if the hemoperfusion is actually very beneficial, or is actually beneficial in our patients. So I hope we can actually be part of generating this evidence by actively engaging in research on hemoperfusion. And I think that's my last slide, and I hope you enjoyed my lecture.
Thank you, Dr. Eric Chua. It's really a wonderful presentation. Thanks for that two initial case studies discussion. It is really gives us when to initiate hemoperfusion and what to expect out of the hemoperfusion. And we could see, like in your retrospective study, where up to 4 sessions, consecutive sessions have been used for those patients in the hemoperfusion arm. So we really would love to see the paper gets published, and I'm sure this kind of an initiatives would strengthen the awareness among the medical fraternity on this technology, like hemoperfusion technology on cytokine removal and treating cytokine storm. And we will have the question and answer session at the end of the, Dr. Shah's presentation. And now I request Dr. Rtiesh Aggarwal sir to give a presentation on hemoperfusion as a potential adjunctive treatment in COVID-19 India experience. Dr. Rtiesh Aggarwal, kindly share your presentation, sir.
Shall I share my screen?
Yes, sir.
Is it visible?
Yeah.
And am I
it's
audible well?
Yeah, sir, very well.
Okay. So good evening, everybody, and greetings from India. And thank you, Delvin and Jeffron, for inviting me and for speaking on hemoperfusion as an important treatment adjunct for critically ill COVID patients and sharing our experience. I will be starting with the brief pathophysiology of cytokine storm and how it is clinically relevant for us as clinicians in deciding the therapy. And then I will take you all through some case scenarios in ICUs, wherein there would be a decision to be made regarding advanced therapies in severe COVID. And while discussing these cases, I'll share our experience, learnings, and evolution during our journey. And in the end, I'll share some data from our ICU. So in response to coronavirus infection, the first immune response from the body is the innate immune response. And as you all know, that the innate immune response is driven by neutrophils, monocytes, macrophages, dendritic cells, and natural killer cells. These are the cells which come into play. They release cytokines, and then with the help of these cytokines, they tend to phagocyte the external attacker, that is the virus. The another important innate immune response is type 1 interferon, but unfortunately in viral infections like MERS and SARS-CoV-2, there is a suppression of type 1 interferon production. So this is not a predominant mechanism. Once the cytokines come into play, they lead to activation of the second line defense, which is the adaptive immune response. which is predominantly driven by T cells, and of those, predominantly by the cytotoxic CD8 T cells. And these T cells cause the lysis of infected cells, and that's how the adaptive immune response works. So basically, the important cytokines which are released during these process are interleukin 1, interleukin 6, interleukin 10, 18, and TNF alpha. When the nature of insult is such and the cytokine release is huge, this is called as cytokine storm. It just sweeps away the whole body's system. And this is called cytokine storm because it starts attacking our own body. So the organs itself starts getting damage, which is called as the end organ damage. The same thing has been shown here also. So there are pro-inflammatory mediators and there are anti-inflammatory mediators always. But in cytokine storm, the pro-inflammatory mediators, they sweep over and take over any anti-inflammatory action and lead to what is called as the endothelial dysfunction. And it is this endothelial dysfunction which is the core principle and at the heart of all the end organ injury. That is injury to liver or kidney or heart or blood vessels. Now, this is an important concept which I would like to bring your kind attention to. All of you who are involved in treating the COVID patients must have observed that the SARS or the inflammatory response in sepsis is different clinically compared to the inflammatory response in COVID-19. So what happens in sepsis? In sepsis, when there is a SARS, there is a simultaneous involvement of various organs. There is a hypotension, there is a hemodynamic instability, there is an injury to the liver, there is an injury to the kidney, there is an injury to the brain, there is an injury to the heart. Vis-a-vis, when it comes to COVID-19, it seems that the injury seems to be localized to the lung only. There is an inflammation which is localized to the lung. It doesn't usually get significantly spilled over to other end organs. Why is it so? And what happens in cytokine storm? When it comes to cytokine storm, then the picture in COVID starts mimicking as if it is a surge in sepsis. So why are there two phenotypic patterns in COVID-19? The answer lies in the pathophysiological mechanisms of innate immunity. So there are two pathways of innate immunity. Let us understand briefly each of these pathways. The first pathway is the PAMP pathway, wherein the pathogen, which can be a virus or which can be a bacteria, the pathogen contains the pathogen associated molecular patterns, and these pathogen associated molecular patterns or PAMPs are recognized by the antigen presenting cells or APCs, and it is these APCs which then activate macrophages, PMNs, and T cells, and then the whole cytokine reaction starts, the cytokine release occurs, and there is a systemic response. Compared to this, the other pathway is the DAMP pathway. So what happens here is, in case of DAMP pathway, the damage associated molecular patterns, these particular patterns are not, they are always there within the cells, but when the cells or the system gets stressed, they are expressed and they are released, and they are then recognized by the APCs, and there is a cytokine release. So what is the difference? The difference is that the PAMP pathway has a tendency to go systemic, whereas the DAMP pathway has the tendency to stay localized. So the inflammation stays localized. So what is the clinical implication? The clinical implication is that in most of the scenarios in COVID-19, it is the DAMP pathway which is predominant. This is what is the understanding which is developing now. That is why the inflammation is localized to the lung. However, when it comes to cytokine storm, then the PAMP pathway becomes predominant and the whole insult and the response becomes systemic, and that's why in cytokine storm the end organ involvement starts happening. So how can this information help us as clinicians? What I'm trying to come to is that if there is a systemic involvement, if there is an end organ involvement, please understand, irrespective of whether your cytokine levels are too high, too huge, or less high, if there is an end organ involvement, please understand that there is a PAM pathway predominantly in activity, and it is an indicator that patient is having cytokine storm, and this is one way of recognizing cytokine storm early. Having understood this, let us go through some case scenarios and let us understand and learn through them. The first scenario is a 68-year-old male diabetic man with an uncontrolled diabetes. He was admitted in wards with COVID, with initial oxygen requirements being low, 2 to 3 liters. Usual initial standard of care with remdesivir, steroids, dexamethasone, and low molecular weight heparin was given. On 5th day of his hospitalization, his oxygen requirements are increasing and it has gone up to 15 liters per minute. Patient was shifted to ICU and his steroids were increased. 2 days later, there was no significant improvement. His oxygen requirements are still 15 liters per minute and he becomes more dyspneic, more tachypnic. His respiratory rate is high. So, the inflammatory markers and blood tests were sent. And what did we find? We found that the CRP levels are elevated, his D-dimer levels are elevated, and his interleukin 6 levels are elevated. His creatinine level, which was 0.6, has also increased to 1.1, and of course, his oxygen requirements are increased. So, in this clinical situation, my question would be, what would be your next line of action? Would you like to wait and watch and continue on same line of treatment with increased dose of steroids? Or you would like to add tocilizumab to this patient, having understood that interleukin 6 levels are high and it is 7th day of his ICU stay? Or you would like to introduce cytokine filtration or hemoperfusion at this stage, understanding that his cytokine levels are high. So before I give answer for this clinical dilemma, let me quickly take you through the accepted indications of hemoperfusion in COVID-19. So the accepted indications are any patient who is having severe COVID-19 plus any of the following, which includes either ARDS, or the patient is in shock and requiring vasopressors, or the patient is in acute kidney injury stage 3 or requiring dialysis, or I would also add, or the next one being if the patient is on ECMO. And the next indication is based on the inflammatory markers, the patient is having an elevated markers of IL-6 more than 100. So there are various cutoffs from various guidelines and various hospital protocols. Some keep it as 250, some keep it at 500. A CRP more than 70, ferritin more than 500, D-dimer more than 1000. So in any combination, 2 or more inflammatory markers are elevated. That is the usual accepted indication. What we understood with our experience is that the isolated cutoff level of interleukin 6 as a sole criteria are not a good guide to initiate hemoperfusion. This is because we have seen, and you also must have seen in your clinical practice, many patients wherein the interleukin 6 levels were low, but the patient had a significant worsening respiratory failure. So the level of interleukin 6 and the respiratory failure doesn't always go hand in hand. So then what to do? So we experienced that considering the course of disease along with elevated marker is a better guide to decide when to start cytokine filtration. In other words, if patient is clinically rapidly worsening in respiratory status and his markers are elevated, he is the candidate. Another important guide: any new onset organ failure, whether it is kidney, liver, or blood pressure, along with the respiratory failure, is a strong and good indication for considering cytokine hemoperfusion. Now you can relate it with the pathophysiological mechanism that I discussed in the initial slide. If there is a new onset organ failure, that means the PAM pathway is in activity, and that means the patient is inflammation is becoming systemic, and that means patient is heading or into a cytokine storm. Another important thing which we realized: if you decide to go for hemoperfusion, initiate hemoperfusion early rather than late. Get rid of these cytokines early and don't delay till they start damaging the end organs. And lastly, an important concept: if you have a patient who has got severe COVID-19 disease risk factors like uncontrolled diabetes, morbid obesity, old age, immunocompromised, chronic kidney disease, or chronic liver disease, keep a lower threshold of considering next line of therapy like cytokine filtration, because these patients tend to deteriorate very, very fast. So what is my answer? I would not like to continue same treatment because on this treatment patient is worsening. I have two options. I can go for tocilizumab because we are in first 7 days of disease and inflammatory markers are elevated, or I can go for cytokine filtration. Although personally at this stage I would prefer cytokine filtration over tocilizumab, and I will come to that part when I discuss the comparison along with the next case. Coming to the second case scenario. This is a young female, 45-year, no comorbid condition, 17-day stay in ICU. She has already received remdesivir, plasma, moderate doses of steroids, low molecular weight heparin. She is on ventilator. On 18th day of her ICU, she has a sudden increase in oxygen requirements, though her hemodynamics are stable. On 18th day, inflammatory markers have been sent, and we found that her CRP is high, D dimers are high, IL-6, interleukin 6 are very high, his procalcitonin level is also elevated at 1.2, and her liver functions are deranged. So again, at this point of time, I have to choose the next line of therapy for this patient. So whether I should be giving high dose steroids, whether I should be giving tocilizumab, or whether I should be giving cytokine filtration. All of you must have understood that the patient has deteriorated and she is in classical, clearly cytokine storm. Let us first understand this and then we get back to the answer. So what is the difference tocilizumab as compared to hemoperfusion? You all must be knowing tocilizumab binds to interleukin 6 receptor and it will block the signaling of IL-6 pathway. It has no effect on other major cytokines like interleukins 1, 8, 10 and TNF-alpha. Hemoperfusion, on the other hand, is a mechanical removing of all the major cytokines. So that is the one major difference. One acts on only on one inflammatory marker, the others act on multiple. Tocilizumab has shown to be effective in studies when used early in disease. In fact, the guidelines now recommend tocilizumab efficacy only when it is given as early as first 48 to 72 hours of ICU admission. Very importantly, tocilizumab is contraindicated in situations when in presence of infections, in presence of hepatic dysfunction, if the platelet count is less than 50,000, and in immunocompromised patients. Hemoperfusion is safe in all these situations and is rather helpful. That is the difference between these two. Okay. What had been our journey in comparison to tocilizumab and hemoperfusion? We found that with tocilizumab, we had a very significant increase in our hospital infections. There was a fourfold rise of gram-positive and invasive proven fungal infections in patients where we used tocilizumab when compared to similar severe and critical patients who didn't receive tocilizumab. We found that the infection risk is much higher, especially in these groups: patients with advanced age, patients with morbid obesity, and in situations where we had to give tocilizumab along with steroids, either tocilizumab followed by steroids or high dose steroids followed by tocilizumab. And this was worsening our outcomes. So our strategy in managing a serious cytokine storm in our ICU has evolved with the time. We started, when the COVID came, we started predominantly depending on tocilizumab for cytokine storm, and if the patients were not improving or the patient continued to be in the storm and still having inflammatory markers elevated, we used to add high dose steroid. From there, as we progressed, we started using tocilizumab along with high dose steroids as the main strategy for cytokine storm. And if the patient doesn't respond on that, then we used to do hemoperfusion or cytokine filtration. But then we realized that this combination is increasing the infections like anything. Based on this and our outcome experience, our strategy now is to use a combination of high dose steroids and cytokine filtration as the initial therapy for an established cytokine storm. Yes, we do use tocilizumab, but only in patients who only when the cytokine storm occurs very early in disease, and if we have to use, we use it within 7 days of ICU admissions in the patient, and those patients who classically have no contraindication to tocilizumab and who are young and non-obese. These are the research articles which emphasize the same point of comparing the hemoperfusion and cytokine blockade. So, whether I would be using tocilizumab in this patient? No, I will not be using tocilizumab in this patient. The reason being, number one, this is an advanced age patient. Number two, the duration of ICU stay is long. It is the 18th day of ICU. Number three, this patient has got infection as suggested by procalcitonin, probably 1.2. Four, this patient has got liver dysfunction or hepatic dysfunction. So tocilizumab would be out. Whether I would be using steroids or cytokine filtration, probably I will be using both of them and hit hard and uh, to treat this cytokine storm. Coming to another case scenario, again a young female, 45-year-old, no comorbidities, having severe COVID-19 and cytokine storm. We decided to go for hemoperfusion and the first session was started. Following the start of this session, her vasopressor requirements increased mildly and the oxygen requirements on ventilator also increased mildly. From the noradrenaline increased from 0.06 mics to 0.08 mics, and her oxygen requirements on ventilator increased from 0.4 to 0.5. So what should we do now? Should we discontinue the hemoperfusion session, having understood that she is reacting adversely to the filter, or we stop the perfusion for a few minutes, then start again, or we continue the hemoperfusion but at a reduced flow rate. So this is a problem which those of you who would be doing hemoperfusion on an regular sort of basis, they will understand that this is a problem which you will encounter now and then. Our understanding and experience related to this is that there are some patients who will show this response. We have found it in approximately 8 or 9 patients. This is usually seen in patients who are younger. This is usually there when the levels of cytokines to start with are very, very high. Usually we have seen it happening only during the first session. And of course, we saw it more with the cytosorb rather than HA330. And we found that it usually settles with the stopping of hemoperfusion for few minutes and then restarting the hemoperfusion at a lower flow rates. Although there is no literature documenting this, but we feel that it is likely due to the endogenous catecholamine response, which occurs when there is an alteration in the cytokines level. So whenever there is a sudden reduction in the cytokine levels, this is probably an endogenous catecholamine response to that, which is transient. Coming to the next situation and case scenario, severe COVID-19 with cytokine storm, and the first session is over. In response to the hemoperfusion, there is an improvement in vasopressors, there is an improvement in oxygen requirement and the levels of inflammatory markers. So generally the question would be whether I subject this patient to any more sessions or not, and if yes, how many more sessions should I give once my patient has shown improvement. So this is an article which in blood purification which talks about this particular issue, and they mention that the application of hemoperfusion should be done for a minimum of 3 consecutive days. What is our experience? We had better results in patients wherein we did 3 or more than 3 hemoperfusion sessions. Another important thing is that even if we saw that there was an improvement after first session or second session, we completed the course of minimum 3 sessions in most patients and we found better results. In many of the patients who didn't show any improvement after the first session, we continued the second and third session and we found that in subsequent sessions they showed a significant improvement. Another important thing, the number of sessions were not dependent on the level of interleukin 6 post session. So in our center, the interleukin 6 levels are freely available with a result turnaround time being only 4 to 6 hours. Our sessions were usually 24 hours apart and each session duration was 3 to 4 hours. Coming to the last case scenario. This is a diabetic chronic kidney disease patient, advanced age, with severe COVID-19 managed in ICU. He developed cytokine storm, and as a part of that storm, he also developed acute kidney injury with oliguria and metabolic acidosis, and now he needs hemodialysis. So the question is whether I should do hemodialysis on this patient alone, understanding that the dialysis will take care of cytokines also, or should I do only hemoperfusion with an understanding that it will also remove some uremic toxins, or is there a way that I do dialysis as well as hemoperfusion? So please remember that dialysis removes solutes with a smaller molecular weight in the range of 5 to 25 kilodaltons. Cytokines, on the other hand, have a molecular weight of around 70 kilodaltons, so they cannot be removed by a hemodialysis filter, and vice versa also. They need a different membrane. So that is why you need to have a dialysis filter along with a cytokine filter in this particular scenario. So, a cytokine filter or hemoperfusion filter can be used with the dialysis machine as a standalone system, or it can be used in combination with the dialysis filter as shown here. Now briefly sharing the data from our intensive care unit. We used hemoperfusion in 55 of the patients, and our experience was mainly with the HA330, the Jafran filter. And most of our patients were sick patients and requiring invasive or non-invasive ventilation. If you can see here, 54% were on ventilator, 32% on non-invasive ventilator. Around 34% of our patients were on vasopressors and 14% of the patients were on dialysis. So quite a sick population. As far as timing of hemoperfusion is concerned, 19 patients underwent hemoperfusion early, that is 7 days of ICU, and 36 patients underwent late. Most of our patients, 85%, received 3 sessions of hemoperfusion, 24-hour gap. Few patients received 4 or more sessions. There were very few patients who received less number of sessions, and that was basically because of other reasons. So what was the outcome? The mortality rate in patients who underwent hemoperfusion was 27.2%. If I talk about the general mortality in the ICU in this severe and critical group of the patient, since we get very serious and referred patients, so that is in our ICU is between 42 to 44%. So, but then this is a very small number to compare mortality of hemoperfusion versus non-hemoperfusion group. What is important is the next thing, that is how many showed an improvement in oxygenation after the last session. So just see, 43% patients showed improvement in the last session, and the next line shows how much was the improvement in oxygenation after first session. So 31% showed improvement in the first session. So what I'm trying to say is, even if many patients who didn't show improvement initially showed a significant improvement subsequently. Out of 19 patients who were on vasopressors, there was a significant reduction in vasopressors in 10 patients. And how about the improvement in cytokine levels? So 92.7% of the patients showed improvement in cytokine levels, and this was after the last session, and after first session 78.1%. So this is also an important point, that even the cytokine levels may not show improvement after the first session of hemoperfusion. So to summarize, there is a high mortality in ICU when it comes to severe and critical COVID-19 patient, and cytokine storm is the leading cause of organ dysfunction, morbidity, and mortality. Hemoperfusion offers a new possibility to support different organs. It is very important that we recognize cytokine storm early, start hemoperfusion early, do a minimum of 3 sessions for around 12 to 24 hours apart. That is the key determinant to the success in cytokine storm. Hemoperfusion improves oxygenation, prevents intubation, and improves outcomes. Thank you.
Thank you, Dr. Rtiesh Aggarwal, for that excellent presentation, and taking all of us through your cases. And we all felt like we were in the ICU with you looking at the patients and the journey of the entire treatment and the outcome. Really, it's a very, very interesting presentation. Thank you for that. And already we have run out of time, but still there are few questions which I would like to ask from the two speakers. The first question is to Dr. Eric. Sir, in your presentation, actually, like in the second case, what you have reported, on the first day of hospital admission, I've seen like the tocilizumab has been used on the first day of admission, but after later, 2 days later, there was a worsening of the clinical deterioration, and then you considered using hemoperfusion. Now, the question is, generally like tocilizumab, the dosage, like it is either a 12-hour apart or 24-hour apart, giving the repeated dose, and that to up to the maximum 3 doses. Like, why you have not thought of repeating the tocilizumab? Why did you go for hemoperfusion? Can you just brief on it, sir?
Well, in that case, I think relatively that patient's build is really relatively on a small. So actually, the small size, the patient. So I think the 400 milligram actually we already achieved the 4 to 8 milligram per kilogram recommendation of the tocilizumab. So I think the infectious doctor that's why decided not to give a further dose and decided to proceed with the hemoperfusion. And it was based on the protocol that I showed you in our hospital in KTI. If we achieve the second dose, first dose with the dosage, it's not working, we actually will decide to proceed with hemoperfusion. It's an understanding from our institution that after hemoperfusion, the tocilizumab, after 48 hours, if it doesn't work, then we will proceed with hemoperfusion. That's the reason I think that we decided to go with hemoperfusion.
Yes, Dr. Rtiesh.
Yeah, so I totally agree with Dr. Chua. You see, the recommendations now regarding tocilizumab are now evolving towards giving only 1 dose of tocilizumab. If you give a second dose of tocilizumab, which all of us gave when the COVID initially came, then the benefit of that second doses are very less, and the side effects and complications associated with the second dose, they are huge. So I think now everybody has gone away with the 2 doses of tocilizumab. He rightly said that only 1 dose of tocilizumab based on the body weight between 400 to 600. That is the protocol which one should follow if you are giving toci.
Thank you for that nice answer. And my second question is to Dr. Rtiesh. Actually, like you made a very important point. Deciding or diagnosing the cytokine storm only with IL-6 may not be a right approach, because like you've seen patients with low IL-6 associated with worsening respiratory failure. So you need to look at the panel of inflammatory markers and correlate the clinical condition, and then we need to take a call. That one. And what is your percentage of cases you have experienced like this, sir? Actually, the number of patients with low IL-6 but with the clinical worsening, and you made a very nice point in terms of the difference between this sepsis and COVID-19 in terms of the inflammation, the difference in systemic inflammation and local inflammation. In fact, I have seen many of the doctors sharing when we go for talking about the hemoperfusion. They used to say in sepsis, the IL-6 level usually typically it will be more than 1,000, 1,200 or sometimes 2,000 more like that. But in case of COVID, most of the cases the IL-6 is 100, 200. A few cases goes more than 1,000. So the level of IL-6 also, there is a how the immune system responds seems to be a difference. Will you please just give a clarity on this, sir?
So do not want to sound wrong, and I don't want to give the wrong message also to the audience. So this concept has to be very clear. When I say that understand the clinical context along with the inflammatory markers, I don't want to tell that the inflammatory markers would be absolutely okay or marginally elevated and the patient is showing a deterioration. And I am not suggesting that attribute everything to the cytokine storm. No. What I am saying is that don't look at interleukin 6 in isolation. No, your interleukin 6, so there are so many patients wherein we have observed that the interleukin 6 levels would be only 70, only 80, only 65. But it's the rapid worsening of disease. So what I'm saying is that please take hints from various things, because cytokine storm is something, if you don't act early, then you have missed the bus. So please understand, a mild elevation in procalcitonin, a new worsening in creatinine level, a new hepatic dysfunction, those points should be given full relevance when you are labeling the patient to have a cytokine storm, and one should not restrict oneself only to the level of interleukin 1 or interleukin 6.
Yeah.
That is the point I want to bring.
I hope this gives a clarity on that particular point. Like when we go for diagnosing the cytokine storm, because the time of initiation of treating cytokine storm should be on a early. I think both the speakers have given that in their presentation, like early initiation of hemoperfusion. And here, my second question is to you, also to you, sir. Generally, clinicians must evaluate the cost benefit of a treatment before going for it, because generally in critical illness like sepsis, ARDS, or COVID-19, if clinicians intervene in the early stage with the hemoperfusion and the patients responded better, we don't know the outcome is because of hemoperfusion or because of the standard care. Even this patient would have responded better with the standard of care alone. Whether we burden the patients with the cost of, because this therapy comes with the cost. And sometimes we wait for organ dysfunction to develop, and then we think of hemoperfusion. It becomes late and patient collapse. So it's a kind of a delicate thing, when to initiate hemoperfusion. So that becomes a very common question among the doctors actually. So how do you handle this kind of scenarios?
So there are two important things which I would like to say here. One is, what is early? So early doesn't mean that cytokine filtration hemoperfusion becomes a standard of care. No way. You have to give standard of care to the patient. You have to try antivirals. You have to give your steroids. You have to give your low molecular weight heparin. You have to see the response on that. What I am saying is, if your patient is not responding to initial line of management, then you have to decide what is the next line of management. And the usual options available are either anti-cytokine therapy like anakinra or tocilizumab. Then there is a pulse steroid therapy, and then there are immunoglobulins or IVIG, and then there is a cytokine filtration. What I am saying is, when it comes to advanced therapy, at that point of time, think early, decide early, and start early. So that is what I mean by saying as early initiation of cytokine filtration. So this is not which will be required in all patients or most patients. It will still be required in less number of patients, but let us use this one judiciously. Second thing, you said about the cost benefit ratio in a private setup like ours. This is an important concern, because definitely cytokine filtration 3 sessions, that is a costly therapy. But then you need to sit with family and discuss out why you are subjecting the patient to this therapy and what are the expected outcomes of this. Like in our setup, I always tell my patient that, see, this is an advanced disease and this is an advanced therapy, but I only expect an improvement in outcomes anywhere between 10 to 20%. So I do not guarantee that this particular therapy will pull your patient out of cytokine storm or out of COVID in 100% of the times. So let us give the cost and benefit ratio openly, clearly, and transparently to the family, and then let them decide whether they would like to opt for this therapy. So that is how I follow in my practice.
Fine, sir. That's really a wonderful way, like how to handle this kind of expensive treatments when it comes, because like already patients burdened with so many expenses, like it should be very judiciously used, and there should be a cost benefit to the patient. Ultimately, the patient centric approach is what we are all talking about.
Definitely.
And now the next question is to Dr. Eric. Like how about the difference? Do you see a difference in the cytokine storm between a dialysis patient and non-dialysis patient? Because like you are being practiced in a referral center, national referral center for hemodialysis patients with COVID. Is there a kind of behavioral difference in the cytokine storm between dialysis and non-dialysis patient? And in your presentation, you made a point. Already they are with the chronic systemic inflammation with the uremic toxins. So how that does pose an additional risk for the dialysis patients?
Well, for our dialysis patient, one thing, no, is actually, even though they have a higher probability of having more severe disease, some of our patients actually are more or tolerate the acidosis a little bit compared to a normal people with no CKD or ESRD, because they have been used to those acidosis. So even though they become more severe, they actually sometimes are able to tolerate it better than a normal one. That's what we see in our trend of our patients, you know. So that's why in our treatment with hemoperfusion, we actually combine them with hemodialysis. We actually do it simultaneously in their sessions. And in the second dose, usually, which is the one is not with, we don't only do it with hemoperfusion alone. But in the third day, we again combine it with the hemoperfusion. And we do see that by removing fluids with additional hemoperfusion, our patients actually do better. That's why in my other patients, when in another hospital where I do more of acute kidney injury, as you can see in my example, the cases, I actually combine with ultrafiltration because I see benefit doing it.
Exactly, sir. In your two cases, I have seen that isolated ultrafiltration of that was there with combined with the hemoperfusion. Now the answer is clear. Actually, like, in fact, I thought of asking the question
from the ESRD. That's why I said I think we still need to remove fluids with ultrafiltration, and it also will be corresponding to the ARDS in our patients who have actually fluids in the lungs. And then I do see benefit in doing ultrafiltration in our patient if I combine it with hemoperfusion. Okay, I think I will be able to show the data later on if we are. If one of my associate is able to gather the data, and I actually tell her to compare those data if there's more benefit in combining it with ultrafiltration, and than doing HP alone.
This may be applicable with dialysis patients you are talking about, right? So patients on hemodialysis, both the patients are on hemodialysis with the hemoperfusion.
Yeah.
Or a kind of okay, fine, sir. And finally, you have used extensively hemoperfusion in the last COVID this pandemic. In terms of blood flow, do you feel that an important factor in deciding the cytokine removal? What is the ideal blood flow rate you keep for this hemoperfusion sessions, sir, actually? And yeah.
for the COVID-19, we actually increased little bit to around 250, 200 to 250 blood flow per, which is blood flow rate per minute. In our usual sepsis protocol, I actually only do it around 150 to 200. But in COVID-19, this was actually, we followed the recommendations from China and from the Italy, that actually they said that we have to increase a little bit of the 250 to have more cytokine removed during the sessions. And I think we have been doing it for consistently since with the COVID-19. We try to increase to have more cytokines removed during the sessions.
Maybe in sepsis, the low blood flow rate may be related to the hemodynamic parameters. You should be a little cautious in terms of, I think Dr. Rtiesh Aggarwal has given a presentation, that presentation, more of a vasoplegic shock is with sepsis, where high hemodynamic instability, comparing to the extent what do we see with COVID-19.
Yes.
And sir, my final question to you, Dr. Rtiesh Aggarwal, sir, I've seen the sessions, the duration of session is 4 hours, 3 to 4 hours. And why not we continue the session for 24 hours or so? Why should we restrict with 3 to 4 hours? Because in some places, is using for the duration of 12 hours or 24 hours is also happening. How do you look at it? And can we derive some extra benefits of extending the session up to 24 hours?
We had a thought about this idea that can we extend one particular session's duration, and can we have improved outcomes with that. And when we started this, in fact, there were few patients wherein we would extend the sessions for 8 hours or 9 hours like that. And so, but what our experience was that there was no significant benefit if we extend the session for beyond 4 hours. So when I say no significant benefit, means we always used to do the post-filtration levels of cytokines. We used to see the response of the patient. And then I had a discussion on with our nephrology team, and I think Dr. Chua will be able to explain that better, that if you increase the sessions beyond 4 to 5 hours, or maybe maximum up to 6 hours, if you go beyond that, then the cytokine removal is not further improved or enhanced. That's why we restricted our sessions to this duration.
Yeah, totally agree. No, because in if you read about the resins that are trying to remove the cytokine, it's actually saturated. So even if you extend the sessions, but already the beads that are trying to remove the cytokines is already saturated, extending it actually will not be that beneficial anymore. In fact, we do see in our cases that if we have more prolonged duration, some of our patients actually have a drop of the platelets. So we do have that kind of worry every time our platelets are below 100. We will actually be monitoring closely. And some of us actually do transfuse first platelets before doing hemoperfusion. So if the beads are already saturated, there's no point of extending it anymore because there's no more further cytokines that will be removed. And another problem, of course, is that during the surge, we have to serve more patients. So by extending it more hours, then we will have lesser patients that we can subject the patient to hemoperfusion. So we have to really kind of adjust a little bit on the sessions also. So we can give it to more patients that really need the hemoperfusion.
Thank you so much. And I think we had an extensive discussion on the clinical experience as well as various, both the respected speakers for their wonderful talk and very, very practical experience sharing. That is what is very much required for the other peer group to know more about this technology. So in that way, really nice presentations. So we would like to sincerely thank again Dr. Chua and Dr. Rtiesh Aggarwal sir for sparing such a valuable time. And no words to thanks the medical fraternity during this tough COVID pandemic. The entire world stuck into this struggle. for COVID-19, and you are the frontline warriors. And we know like how much tightly scheduled you are among this pandemic, and despite this tight schedule, you are able to accumulate the data on these cases and sharing with the peer group. Thanks a lot. And I would like to thank all the participants connected for the webinar. And I hope definitely you all would have got a kind of an interactive session, very, very useful. Thank you so much. So with that, I would like to conclude this webinar. Thank you, Dr. Eric Chua, and thank you, Dr. Rtiesh Aggarwal, and thank you all the participants.
Thank you. Thank you.
Thank you so much.
Pleasure.
Thank you. Thank you so much.